Good evening, everyone, and a very warm welcome to all our attendees and panelists this evening to this IIOP in Conversation with webinar on establishing the Common Condition Service. You're all extremely welcome. My name is Dawn Davin, and I'm a pharmacist with the IIOP, and I'm here this evening in capacity as facilitator for the webinar. So just before we get started, I'd just like to say a really sincere thank you to everyone who submitted their pre-webinar questions. We've had some really good questions, and both your questions from the pre-webinar registration and also your questions tonight will be forwarded to the various relevant stakeholders. So just to let you know that it's really important, and we really value how your questions inform the content of the webinars. So thank you to everybody. So a few domestics before we get started. The webinar is being recorded. And the attendee videos and microphones are not enabled for this webinar. You might notice a slight change to our format. We've had such a high number of registrations that we've had to change to the Zoom webinar platform for tonight. As usual, if you have any difficulty with sound, ensure the sound or speaker is not muted or turned down on your computer or phone, and failing that, the old golden oldie of trying to log off and log on again. The chat box is disabled, just as I've explained you to the large number of registrants, but the Q&A function is in operation, and we'd really encourage people to post their questions and comments, and I say they will be collated and forwarded to the various stakeholders. We may use some anonymized information from the webinar, and again, we would also really appreciate if you could complete the post-webinar survey. In addition to the usual questions, we have also included areas of further aspects that you'd like to see addressed in relation to the Common Condition Service, and also the type of resources that you would find helpful in terms of the next phase, excuse me. I will now move on and introduce our panelists for tonight. So we'd like to welcome Dr. Catriona Bradley, Executive Director of the Institute. Hi, Catriona. Susan O'Dwyer, Head of Professional Services from the Irish Pharmacy Union. You're very welcome, Susan. And also Sinéad Lanigan, a Supervising Pharmacist in Allen's Pharmacy. And Sinéad, a very warm welcome to you as well. So now I will hand over to Catriona. Thank you.
Thank you very much, Dawn, and a very warm welcome to everybody this evening who's logging in, and also to those looking at it on watchbacks. My name is Catriona Bradley, as Dawn introduced. I'm the Executive Director of the Irish Institute of Pharmacy, and you'll all be well familiar with the Institute's role at this point in terms of developing and delivering the training for the Common Condition Service. So that's been quite a project during the course of last year in collaboration with the RCSI and the Oversight Implementation Group and PSI. So it's something that over about 3,000 of you have completed and have certification for the core module, 2,500 with certs for the common condition or the condition specific module. So you'll be well familiar with the training, and that's the training that's needed in order to satisfy the requirements to be able to deliver the service. And no doubt all of you have completed your CPD cycle, where you identified the need and you recorded the plan that you were going to have, and how you've acted on that, and what you've learned and how you're putting it into practice. But I suppose it's that putting it into practice that's actually the next cycle of learning. And that's going to be much more individualized approach, because it will require you maybe to even start a new cycle where you need to think about your own self-evaluation, what you need in order to be able to implement this learning now. And how are you going to engage your colleagues, your place of work, or engage with your patients and with other people who may be within your community, be it GPs or other pharmacists. So it's often the case that when we complete one piece of learning, we go into another, and this is one where you now need to identify what you need, and we're delighted to be able to facilitate that insofar as we can. So this is outside of the certification requirements. It's now more about over to you. And we're delighted this evening to have our colleagues from the IPU and to have pharmacist in Sinéad, who you'll meet later, who's able to share insights from early adoption of the service. And I think that's going to be helpful in being able to address any concerns, or to think about, provoke thinking for you about things that colleagues may need to think about, or that you may need to think about. But we also have a lot of the questions that are informing the content of this evening. So we're delighted to have you here. And I suppose the other thing that we're all very confident about is that we've been here before. We've implemented service and we've adapted to new ways of practice. We're well able to respond to the needs of the health service and patients. And so this is just another step in the journey. Albeit that we may need to just stop, take stock, listen to what we need, consider what we need to do to implement the learning that we've had from the courses, and then move forward with confidence in meeting the needs of patients as we always have and as we will continue to do. So for me, it's a very short introduction to say, you're welcome. This is another phase to the learning. It's not the statutory requirements, but it's now much more bespoke and personalized to you, and you're in charge of that yourself. So I'd really urge people to think about what they need in their area, to connect with other colleagues, and to listen to the presentations this evening, because I can guarantee you it's a very rich and I suppose, informative session that we have for you this evening about implementing things in practice, and delighted to be able to host it, and like to welcome, in particular, Dr. O'Dwyer and Sinead in being able to do so. So that's it from me, really, Dawn. I'll remain here in case there's any questions later, but I do trust that the contents of the evening are going to be far more informative for people than anything I can say about the training at this point.
Thank you so much, Catriona. That's fantastic. So, Susan, I'll hand over to you next. Thank you.
Thank you very much, Dawn. Susan O'Dwyer is my name, and thanks for the introduction. As Catriona said, I work in the IPU and I'm the head of professional services there. And just in terms of the Common Conditions Service, I sat on the implementation oversight group, so have some insights there also from how this was developed in practice. Now, that has all been discussed at the last webinar, and you've got that insight around how the service came to be, how the protocols were developed. So I'm not going to be going back over that old ground. This is more around what are the kind of things you need to think about if you're going to deliver the service in practice. A lot of you will have thought through some or all of the things that I'm going to say. Some of you might have thought of some of them and maybe not others. And while there's a lot in it, I don't want that to be overwhelming. It's really just, you might find a nugget in here that will help you in terms of thinking about, I want to do it, I'm getting ready to start, but have I really thought of everything? So just don't get overwhelmed by everything. Just think about, I'm going to start, and there are certain things that I can do, and you'll find something in here that should hopefully help you along the way. So if we go to the next slide, I'm just going to I suppose these are almost like housekeeping things out of the way, but if you intend to deliver the service, you need to register, you need to opt in. So under the terms of the Community Pharmacy Agreement, you need to inform the HSE that you're going to be delivering the service. There's an opt-in form. It's on the HSE website. Now, I'm saying that on a day when I know the HSE website is not actually working. There has been some technical issues in the background. So accessing sites like the Community Pharmacy Agreement page, where you'll find the CCS opt-in form, and even the protocols actually have been challenging the last day or two. But I know the HSE are working hard on that, and we hope that that will be addressed and resolved in the coming days. Um, in addition to filling in the opt-in form, and actually one of the things you're saying when you fill in the opt-in form is that you're sharing your details with the HSE and you're putting those details on the pharmacy finder. But it is a separate process to get those details on the pharmacy finder. So the opt-in form is the first step of the process, but then you need to go to the pharmacy service listing request form and you need to input your details and say that you want to be live on the CCS pharmacy finder. But it is a condition of offering the service that you do submit your details on there. So if you submit that form again via the HSE website, you can change some of the details that you put in over time. You can update your details. You can change times, for example, when you're offering the service. But initially, just get yourself set up. So then if we move on to the next slide, Catriona's talked about the training, and I'm not going to talk a lot about the training. There's a lot of training out there for pharmacists. I want you to think maybe a little bit more about the rest of your team and maybe the internal kind of training and processes that you might need to think about. So you'll have done your clinical training, you'll have done your core module, you'll be familiar with the legislative pieces, but then as you get into thinking about how it's going to run in your pharmacy, there is training in terms of what are the standard operating procedures that you're going to develop? How are you going to run the service in your pharmacy? And how do you train yourself and your team on those particular standard operating procedures? And there might be some staff that will do a bit of one SOP and maybe not relevant to some of the other SOPs, and then there'll be pharmacists that will be doing all elements of the service. So just think about that, and that's part of your training and part of what you'll be doing with your team. Also think about the needs of the entire team. So your healthcare advisors, your medicines counter assistants, they're in many cases, and probably in most cases, going to be the first person that the patient sees when they come into the pharmacy. They're going to be engaging with your patients every day on the healthcare counter. They'll be recognizing people that will have symptoms that might be consistent with some of the services that are being offered under the Common Condition Service, and they'll be a key member of your team that will be able to refer patients into the service should they feel that that's a service that's suitable for them. So there's training needs there for your entire team. And for some people, it'll be a bit more detailed. For others, it's as simple as we're going to be offering this service. What does the service involve? How does it run? How does it work? What is it? And you maybe want to think about giving your entire team a briefing, and then maybe a more detailed briefing for your healthcare team or key members of your team that you want to get trained up to do a little bit more in relation to the service. I would advise when you're doing that, just check people's understanding. So you might give a briefing to the team, but maybe ask some questions, maybe get them to explain back to you what they've heard and what they've understood. Because sometimes just by asking the question, you find things that you didn't know. And maybe something that might seem very obvious, actually in hindsight mightn't be that obvious at all. So think about how you're going to engage the team and how you're going to train them up on what the service looks like. And when you're doing that engagement, I think another important thing to think about is where are people in the journey? So some people will have heard about minor ailment schemes over the years, will have been wanting this service to be implemented in pharmacy, and this will be a very welcome step forward in their scope of practice. For others, they might never have heard the word. They don't know what a common condition is. We don't know what we're talking about. And then others still might be nervous and go, oh, I'm not sure if I want to do this. This is going to be on me. If I'm a pharmacist, you're like, how am I going to fit this into my day? So you need to just hear the opinions of all people. And then there might be some people might have concerns around what am I going to do if a patient that has a medical card comes in and I want to be able to offer it free of charge, but I can't do that because it's a private service. How do I manage that consultation and that conversation? Um, I can't tell you that we can give that free of charge. So you need to figure out, well, what are the ways that we're going to be able to manage that conversation? And importantly, if we can't offer the service in the pharmacy, what do we need to do for that patient to make sure they can still get access to the care that they need in a way that suits them? So take time to listen to people's opinions, their suggestions, their concerns, see where they're at on the journey so that you can support everybody. Don't make assumptions about where everybody is. But equally, don't let the fact that somebody might be concerned or a little bit nervous put you off the engagement process and being able to work through it. It just means that we might need to take a different approach or a little bit more time with one person versus another, depending on where they are on that journey. So then if we move to the next slide, I think a really important thing to think about when you're getting ready to implement any service is what's the workload in your pharmacy currently, and how are you going to fit this into your workload? How are you going to change your workflow, or are there changes required to your workflow? So you'll have thought of this with things like vaccination services in the past, and this is now, yes, it's a year-round service, so it's not quite the same big peak at the very beginning and huge demand. This is something that would be, you probably see less people every day, but you'll be seeing them consistently over the course of the year. So how do you manage that? What is the workflow changes that you might need to put in place? Are there different things or different times a day when you do certain tasks that actually maybe you should do them at a different time now? As you start to deliver the service in practice, you'll start to see when do people actually come for the service? Are there certain times a day that people actually turn up and say, can I have an appointment? Can I talk to you about the common condition service? So over time, this will probably evolve. And you might say, God, there's a lot of people come at lunchtime and they really want to talk to us about common conditions when they're on their lunch hour. Is there something we can do to support them with that? Or actually, do we have to have appointments and tell them to come back? So you just need to think through what are the tasks that we need to do? When do we currently do them? Could they be done at a different time? I'll give you an example. Let's say you didn't have a system for getting your prescriptions ready in advance and you just did every prescription as it walked in the door. Then you might think, actually, if I did these in advance, got that done and out of the way before people were attending for the service, that would make the workflow a lot easier and I could manage my tasks a bit better during the day. So just that'll be different for everybody. So just have a think about that and bring your team together and have a think about it. As I say, how do you manage it for other services? But also, you will still be continuing to deliver other services. So, your emergency contraception service will be delivered. Maybe not so much vaccinations at this time of year, but there will come a point where you're managing vaccinations and common conditions. How are you going to manage that? And how are you going to know what patients want what when? How are you going to set up your appointment diary if you decide to do that? If you want to offer appointments, how many appointments are you going to offer in the day? How long are you going to have an appointment for? Is it going to be a 10-minute consultation? Is it going to be a 20-minute consultation? That's something that you'll probably you'll see that develop over time. But I guess you're talking here about a consultation for a common condition that GPs would do frequently, that they tend to do in kind of 10 minute, maybe 15-minute slots. So those are the kind of timeframes that might potentially seem reasonable, but it will be what works for you and your team. And you might find that your consultations take a little bit longer at the beginning, and they don't take quite so long as you get used to it and you get familiar, and depending on the protocol, how often you're doing it, etc. But just have a think about that and what time are you going to allow, particularly if an appointment diary and you need to set those times. But also if you want to leave some slots free for walk-ins, or if you know there's busy times a day for prescriptions and you don't want to offer appointments at that time, just have a think about that. And really importantly, who are all the people in the pharmacy that can do different tasks? Are you delegating any tasks that you can delegate as a pharmacist to other members of staff and training them appropriately to do those tasks? Are you distributing the workload equally among the team, or are you thinking it's the pharmacist that has to do everything? And the pharmacist can't do everything. So how do we utilize everybody within the team, and how do we make sure that we have enough people at the right times? And what kind of a profile of staff do we have? Do we need to get an extra pharmacist in a certain day? And you might not be able to employ a new pharmacist at the outset because you don't know what this service is going to involve in terms of patient numbers, demand, etc. But there might be ways that you can start to figure that out slowly. And over time, once you know what's happening in your pharmacy and the kind of demand there is, you can look again at your profile and see, does it match what you need? And briefly on insurance, the thing to mention here, your insurance provider, they need to know that you're offering a particular service to be able to cover it on your policy and to be able to make sure that you are covered. So what we would say is, for anybody who has a policy, you contact your insurance provider. So any owners, are you covered? The insurance provider may ask for a description of the service. Generally, they're looking to see that there's legislation underpinning it, that there's guidance from the regulator, and you've got all that backing for this service clearly in terms of everything, the way it's been set up. But just check in with your insurance provider. Are you covered for this new service? And if you're an employee, discuss, and I mean employee that's working every day in the same pharmacy and a locum pharmacy equally, check with your employer. Does their policy, and are you covered on that policy if you're delivering the service in the pharmacy, and does it extend to that? So just make sure you do check that in advance of delivering the service. If we go on to the next slide, I think the next piece of advice I'd give you is put yourself in the mind of the patient. So what is the journey that the patient goes through to get right through from start to finish? And the first thing is, do they know anything about the service? So what's their awareness of the service? Do they know you're offering it in the pharmacy? It might be as simple as, do you have a poster in the window? Do you have a website and you have information up? Do you have your staff trained that they can tell people about this service now available? There will be online or national awareness campaigns. So the department are running an awareness campaign currently informing people about the service. And you'll see other campaigns like an IPU campaign in the coming weeks. But for yourself locally, how do people know that it's happening in your pharmacy? So the pharmacy finder is the first place where they can become aware. And those conversations, either in person, over the phone, if you have email services where people can email in, just think about how you raise that awareness. We've talked about appointments and walk-in and what you're going to offer. Then there's that screening piece, and the screening piece can be online, for example. So you might decide to do some element of an online journey where patients book in, maybe do an element of a triage online, where you can ask a few key pertinent questions. And if the service is not something that's going to be suitable, let's say the person falls outside of the recommended age range, they very clearly know that at the outset, and they're not unnecessarily booking an appointment, coming in and then being disappointed. If you want to do some of that triage and screening online, you can do so, but it is important that the patient has to turn up to the pharmacy to have a face-to-face consultation with the pharmacist to go through the whole journey. So there has to be an in-person element, but elements of it can be done online. In terms of the service itself, if the patient is going to access the service, they need to know what they're signing up for, that you're going to do a consultation, you're going to bring them to the consultation room. It's very structured. There's a lot of inclusion, exclusion criteria. You're going to take information from them. You're going to make an assessment to help in the diagnosis, that there are potential outcomes from that service. And those outcomes will always include advice. They may include referral. They may include the provision of an OTC treatment, or they may involve a prescription. Now, there could be a number of those options, but it's important when people are going into the service that they don't think at the outset that what they're going in is to get a prescription. They're going in to have a consultation with a pharmacist to assess their symptoms and see what the recommended outcome is. And that could be referral or it could be prescription. So think about that when you're having that conversation with the patient so they're fully clear what they're agreeing to do and signing up to and consenting to, I guess. But it's also important then to have that conversation so they know what to expect. So you very likely charge the patient a fee for the consultation before they go into the consultation room. It doesn't have to be that way, it can be afterwards as well. But they're paying for your expertise and they're paying for that consultation and that assessment. They're not paying necessarily for a prescription. If a prescription is issued and there's a supply of medication, they'll be paying for the medication or they'll have the eligibility under the drug schemes. But what they're paying for is your expertise. So I can't tell you what to charge. I can't tell you how to do that, but just value your expertise and make sure that the patient knows what the various different outcomes could be, because that can help with some of those situations where you might get to the end of the consultation. There is no prescription, but the patient didn't necessarily expect that that would be the outcome because you've clearly told them that at the beginning. I'm conscious of time, so I'm going to fly through a few of the other pieces, and if there's any questions, people can, of course, put them in the Q&A, but really just think about your waiting area, think about your consultation area, think about what the consultation room looks like. If you're storing stock, which if anybody listening from the PSI, we know you shouldn't be doing that, but this is a clinical area, and there are guidelines around what a consultation room should look like. You want to make sure that this looks very clinical. It's as it should be. You're not using it for purposes that it's not supposed to be used for. It is a consultation area for patients. So be very conscious of what a patient sees when they go in. How clean is it? Have you got the right equipment? Have you got what you need in terms of your consultation record forms, etc.? Think through the consultation process, and Sinead will give you some tips on that, so I'm not going to dwell on that. I'll just mention that you do need to make a record of the consultation, and there are standard consultation record forms. So there's a consultation record form in the operational guidance document that's on the HSE website, and you need to have those details captured on the form. So that's a kind of a form that was agreed by the IOG. You can use variations on that form, as in you could create your own form, but just make sure you're aware of the data fields that are on that form, because that's what you should be capturing as an absolute minimum. You need to be recording that you've captured consent. That doesn't necessarily mean that you have to have a patient signature, although you may well choose to have that, but it needs to be an informed consent process and you need to document that you did capture that consent. Manage your time in terms of how you're flowing through the consultation. Some people will be using things like pharmacist assessment forms that incorporate details that are on the consultation record form. But really, you need to think about, how do I bring them to life in a natural kind of a speaking voice? How do I ask the questions that allow me to capture the detail in the right way rather than necessarily reading off a form? And that just comes with practice, to be honest, as you go through the service. A couple of people have asked around generating a prescription, so I'm just going to touch on that briefly. So if you do decide to issue a prescription, you need to do a couple of things. So you need to record your decision to issue the prescription in the PMR, because that decision to issue the prescription needs to be on the daily audit. Then you need to write the prescription. So there needs to actually be a prescription. And that prescription, if it's going to be dispensed in the same pharmacy where the prescribing occurred, you still have to send that prescription effectively to yourself. So if you want the prescriptions to be dealt with via health mail, you would have to health mail an electronic prescription to yourself. If you wanted a paper form, you could have a paper prescription and you could dispense that in the pharmacy. Now, we do recommend an electronic journey, but that it depends on what works for you. But you do need to have a prescription. That's one part of the process, and that prescription then needs to be presented for dispensing in the pharmacy of the patient's choosing. So that may be the pharmacy where they got the service, or it may be another pharmacy, and you need to make them aware that they can take it elsewhere if they want to, but where they want it in the pharmacy, that's not a problem at all, but you just need to separate out those two pieces. In terms then of just, if we just go to the next slide, I just want to give you a few little things to think about, and this is when you're post-implementation. So, if you've just started up, the first few days, the first few weeks, just take time to think about, have you got any feedback from patients? What do you think the experience was? What's the experience for the pharmacist delivering the service? You as a pharmacist, if you're delivering it, what are your insights from what you did well, what you maybe could do better, how are you going to prepare for the next one? That kind of thing, but also with your team, how did the referral process in work? How did the reception process work? Are you managing your workflow well? So just take that time to talk together as a team to see what's been the impact of this service being implemented. What changes did we think we need to make? Did we make them? Did they work well? Is there any things that could work better? Are there any things we didn't think about at all? Are there any unexpected consequences? So now do we need to make any other changes? It's a dynamic thing, so it's something that will change over time. And then that will tell you whether you need to have any additional training, whether you need to do something with your marketing materials or your information materials that you provide to patients. Might tell you something around whether there's other conversations that you need to have with local healthcare professionals in terms of referring, etc. And just spend the time to think about what's working, what's not working, and what do I need to do differently. And on that note, I'm going to hand over to Sinead, who has a lot of experience in delivering services such as this and will be able to tell you some of the things that she's learned as she goes along, which I think should help in terms of practical, pragmatic support at this stage of the journey. Thanks, Sinead.
That's great. Thanks, Susan. So I'm Sinead Lanigan. I'm a community pharmacist working in Dublin City Centre. I've been asked to come on tonight, obviously, just to talk about my prescribing experience. So I worked and prescribed in the UK for 7 years. I had standard prescribing, which was done under the minor ailment scheme. And then there was also advanced prescribing, which I did under a patient group directive. I prescribed for a range of conditions. There was 32 in total, ranging from kind of acyclovir to paracetamol to more complex and simplified things as well. So on the next slide, just to say that my overall experience as a prescriber was incredibly positive. There's huge professional satisfaction in doing such a level of clinical skill, which we trained for in college. Ultimately, that's what we trained to do. The patients have a really high level of engagement. They tend to very much enjoy getting one treatment process, one package of treatment from one healthcare professional. There's a very easy flow of treatment, and they have to do very little in terms of just coming into one place, getting one treatment, and leaving the entire experience as one. So Susan has talked about kind of the external factors, and look, we all know that there are definite pressures in setting up and the logistics of the service. But for the sake of what I want to talk about in this is for you to imagine that you've now just gone into the consultation room. You're not here at all to provide good value for your consultation. Your mind frame needs to be that you are here for clinical purposes and for a clinical assessment. So the next slide looks at the 5 principles of good prescribing. They're outlined by WHO, NHS, the HSE, we all follow them. So firstly is to define the problem stated by the patient, and that's in the patient's own language and explanatory factors. The second is that the prescriber specifies the diagnosis. Thirdly is to complete the medication safety assessment. 4 is to choose the treatment plan, and the 5th is to explain the medication and the treatment plan to the patient. So today I'm highlighting 2 of those that I found to be particularly important during our consultation process. The next slide looks at the priority of diagnosis. So we obviously know our training is the most important thing that we can do to feel confident, to upskill ourselves, to do all the IIOP work, to use our IPU resources. But I did find that practically along the way, sometimes it's not a 2-hour webinar. They're all hugely beneficial, but don't underestimate the day-to-day things of a 5-minute revision of something on the medicines.ie. If it gives you more confidence on a question that you got asked in a previous consultation, you may want to do a simple looking up of visual triggers for you on screens to see what certain rashes or our impetigo and shingles might look like. So your training can be as complex or simple as you want, as long as you use it to support your diagnosis. So 2 aspects really for the diagnosis is that ultimately the patient themselves want a really clear diagnosis. They're here today for you to hopefully be able to diagnose and tell them what's wrong and then get a treatment plan. But most importantly for me as a practitioner, it safeguards me because I need a clear diagnosis so that I can now follow the prescribing treatments for protocol. So if we take the allergic conjunctivitis versus bacterial, you have to clearly define which one it is, because only then you can follow your flow chart for prescribing. So big topic that came up during our training and was a recurring theme for us as we expanded our services and learned about new conditions was pharmacists were concerned that we didn't have diagnostic tools, unlike the GPs, in order to aid our consultation phase. So it's very clear that if I would feel more confident as a prescriber, if I had a clear urinalysis and it was positive, I could treat for trimethoprim. But the reality of the situation is that all of these forms and of training are set up that we can do a diagnosis based on symptomatic description alone and consultation with the patient. So there is huge reassurance that, as Susan described, like all the protocols and the prescribing guidelines have specifically been set up and developed by specialized groups. There's pharmacist representatives on those groups. They knew the limitations that we faced and they know what we can do in the confines of a community pharmacy consultation room. So there's huge reassurances that everything that all the forms that we're working for have been developed with that, bearing that in mind. The next slide is to talk about explaining medications in a treatment plan, and this might seem really unusual that I'm highlighting this particular issue to talk about, because surely as pharmacists, like this is what we do on a day-to-day basis. But one of the things to remember is that don't let the fact that you do it on a day-to-day basis, it doesn't carry any less weight in the consultation as any other aspect to it. Just because you're very used to talking about medications doesn't mean that the patient is very used to talking about these medications. It is also a change in mindset for us, because there previously was safeguarding measures in a certain way for a patient. They had two interactions with a healthcare professional. So they went into their GP, they got all their information from a GP, and then they come to us. And a lot of the times we just reinforce, not just reinforce, but we do reinforce and give them a further clinical treatment, further options to ask questions. And now there's only going to be one person providing and reaffirming all that information. So we may need to think about how we explain our medications and really making sure that the patient understands them in a much more clear way. A very simple thing I did was to make sure I always asked one closed question. So for example, if I was asking Mary how many days I specify, how many days did I say to use that antibiotic for? It gives me a little bit of an indication maybe of her understanding if she was picking up some of the information I was giving her. By all means, have open questions, but as Susan said, time factors, you do want to have some clear closed questions that you can work from. The patient wants a really good outcome of treatment. That's obvious. We want a good service to be run. And again, that's quite obvious. And we want to be successful in this new clinical skill that we're developing. Statistically, all that being a success, a lot of it relies on, a lot of like the best patient outcomes rely on the patient engaging in the treatment plans, but also very importantly that they use their medicine to the therapeutic treatment dose and therapeutic duration of treatment. So again, reinforcing that in your consultation leads to hopefully better outcomes for both the patient and for our service provision. So the next slide is regarding signposting and safety netting. Again, both there for the patient, but really important for you as a prescriber. There was no failure on service on our part that was viewed if we couldn't complete a consultation, because there are a lot of things that just are outside of our scope of practice, and signposting is a reality. So if you haven't or you cannot complete a medication supply, have you already considered what you will do with that? So obviously the protocol is for referral, but do you have a practical way already in place, or are you thinking of putting a way in place that is a written referral form that's clear and concise for your patient? So when we created referral forms in the UK, we did have to use one of the phrases we had to use was that under the scope of practice, I I cannot complete the consultation for this patient for X reason. X reason was one of the, the exclusion criteria that was on our form. So it was a direct match to that exclusion criteria. And then if you needed to add one or two other sentences, that was fine. But try not to don't write too much information. One or two sentences does tend to be sufficient. The real importance of written information or emails to the GP or any communication that is passing through the GP and the patient and us is you don't want any risk of miscommunication, especially if you're transferring clinical information. The patient might not always be the best person to relay that back to their GP. The other issue of safety netting that we had to do, it was simple, but it was on the very last piece of our process. So when or our techs, whoever was dispensing the medication, if they were doing the UTI protocol, for example, for trimethoprim, and they dispensed 6 tablets and they said take one twice daily, that wasn't viewed for us as being a sufficient level of instruction. What we did was we wrote down take one twice daily. We specified it was for 3 days only. We also wrote, if your symptoms worsen or do not improve after this treatment, please contact your GP. So again, a small referral for the patient and a safety netting factor for you. The next slide is just to talk about complex consultations. So I found this a little bit difficult to talk about in the length of time, but I'm just going to give my first-hand experience, which is what I'm here to talk about. Polypharmacy, like really complex patients, will naturally be like the most concerning cohort that all of us are probably concerned about prescribing for. We face the most challenges with these patients, not just like as new prescribers, but as long-term prescribers, or a new medical service may come on board and we're learning new things again. So these are patients that would have like polypharmacy, so more than 5 medications that they have at once. They may have multiple medical conditions, number of risk factors, or something like breastfeeding. In my experience, these were actually the patients that I was exposed to the least. We had a bit of an assessment within my district of prescribing as to see over time, we always examine this, as to see a reason that we may or may not have more or less contact with any particular clinical subgroup. We did find that the most complex patients had a good relationship built in already with their healthcare provider. They mightn't see you as the pharmacist as the first port of call. They have a high GP visit rates. They may already be linked into oncology, dialysis, or maternity units. So all those patients that you may be really concerned about first seeing. Anecdotally, I can only tell you that my exposure rates to complex consultations was lower than I had originally anticipated and experienced over the whole process. The next slide is just for some consultation aids, and some things will sound very basic, and I would always say, please don't underestimate a basic tip or aid or trick, or to give yourself time as new prescribers. So before you go into the consultation room, just give yourself a moment, make sure like you're familiar with the form. If you know, for example, that this patient is possibly going to have shingles, try and engage your brain to say, right, shingles, this is what I'm thinking of. These are the particular questions that are always really important to me, or that these are any red flags that I'm going to be looking out for. In a practical sense, if you have a regular pharmacy, regular customers, can you look up the patient's PMR before the consultation? If you did check the PMR, is there anything there that would help in your decision-making skills? Or again, maybe a red flag in their PMR that would make you ask a couple of extra questions for them? For example, is the patient asthmatic, or could be anything in their PMR? A number of prescribers, in particular cases when we were dispensing antibiotics, were particularly concerned about allergies and allergic reactions. Again, if you're lucky enough to have a lot of time or to do all these kind of tips and tricks, you could just search to see if that patient has already been prescribed nitrofurantoin in the past. If they did, again, you know, there's less likely of it being an allergic reaction unless it's documented or side effects occurring. So it can be a tool for support for you. The number one thing I would say for resources that you're using is to have those resources like clear and easily accessible. So the protocols are fantastic, but the reality is they're kind of 17 to 27 pages long, and it can seem intimidating if you're trying to sort through that length of a document to get a piece of information. So for some things you can consider very easy flow charts to create. So Schedule 13 drugs are the list of drugs that we are allowed to prescribe under the Common Conditions Protocol. The system we had in the UK was that you would create essentially like an A4 page or a flow chart, and the A4 page would have all your medications listed on the left-hand side, and there'd be 4 columns, like our main 4 to look out for were pregnancy, breastfeeding, renal function, and patients under 18 years of age. And then simply in the adjoining column, say for example, trimethoprim, you would have a tick the box yes or no if it was safe for the patient to use. That kind of chart was at the front of our, or whatever way you want to do it now, digitally or in front of our folder at the time. And it was just so clear and quick and easy to refer and to have access to, that for me personally, it was a really, really good tool in practice to use. So finally, again, just a few practical tips on consultation. As Susan said, just like real organization, it sounds so boring and basic in a way, but if it helps your service run smoother, have your forms ready, have referral letters ready, leaflets of information, like don't underestimate how smoothly that makes your process go. My number one kind of priority that I personally am making for my consultation room, that I didn't quite have the same support in the UK, was I definitely want digital support as a priority. So I have either a laptop or a tablet set up in the consultation room. I want to have easy access to information. I want to be able to access all my guidelines easily. I want to be able to open a tablet and show the patient the HSE.ie, you know, conditions A to Z, give them a quick look if they wish to do so. Particularly maybe important considering some of the IT issues that have been happening with the HEC website today. A really good tip is to have your protocols saved as PDF format so that they're there all the time on your digital device and you can access them at any stage. A reminder that all contractors received grants to set up the scheme, and IT grants that will be coming through the community pharmacy agreement. So if IT wasn't a particular, you know, factor that you considered, I would personally really strongly advocate for it to be in your consultation room. The last point, because I'm running over, but the last point is so simple, but please do not do a brilliant consultation and then come out, have your prescription dispensed and not have the stock. Make sure that your dispensary team are aware of the stock levels, that maybe new stock levels that you need to have and to keep, and to be highly aware of stock shortages when you are prescribing medications. So make sure you have the support of your dispensary team for that. So that's it. In conclusion, I hope maybe you got one simple tip or a bit of help. Like I said, it was a really successful and enjoyable journey for me, and I hope that we all have the same experience when we're setting up the Common Condition scheme. I'll just hand back to Dawn then.
Super. Thank you so much, Susan, prior to Sinead, and thank you, Sinead. I think just personally listening to everybody, including Catriona at the very outset, the word that's coming up a lot is journey, in terms of the patient journey, sort of as you're alluding to, Susan, mapping, you know, the processes and that journey, and then the pharmacist journey, and really, you know, building on the skills as you've outlined, Sinead, that we have as pharmacists. So I just that sort of image comes to mind a lot. Just before I move over to the questions, I just want to, you know, reiterate that the practical nature of the support is fantastic, and thank you to all the attendees. So many of your questions submitted have been addressed by Susan and Sinead tonight, so it's really been of huge value to to have those questions in advance, and it really does shape the information and what people are keen to hear about. So I think that's fantastic, and just wonderful tips and practical guidance, Sinead, there very lastly as well on the whole prescribing process and the practical aspects that go with it. So thank you all so much. Maybe if I could just start with one practical question that's come in. Are there posters or leaflets available anywhere to print? Maybe Susan, if I could direct that one of you, if you wouldn't mind.
Yeah, so not to be necessarily highlighting IPU resources, but we have posters that we're making a digital file available to members and they can download that and print it locally. So that's something that can be displayed in the pharmacy wherever you choose to display it. There will be digital assets coming when the media campaign is launched also that people can use for social media, etc. There isn't any other source of posters that I'm aware of. In terms of leaflets, and I know some people had asked about, where will I give a patient a leaflet with information afterwards? You'll see within the protocols the kind of information that people are recommended to give to the patients in terms of advice and self-care advice, but also in terms of signposting to the HSE A to Z. So all the HSE A to Z pages for the relevant conditions have been updated, and we would signpost people to them. But like Sinead had mentioned as well, maybe some people will want to print out or need to print out, and it might be useful to have something to hand over. But if people have access to those websites, that's a place to signpost them as well. Just
Brilliant.
while I'm talking about posters, actually, Dawn, I might just take the opportunity as well to mention that any pharmacy offering the service must use the common condition service branding. So there's a common name, it's the common condition service, there's a common logo, and that must be used by all pharmacies when they're talking about the service. So you can't call it Susan's common condition service, it's the common condition service, and it has that logo, and that must be displayed. The access to that logo, the guidelines for its use are on the HSE website, so that same page where the protocols are. So once that's back up and running, you'll have all that in there, and you can download the files to use as you need as well.
Brilliant. So really easy to access. And I suppose just a reminder as well about the PSI guidance that's available to pharmacists as well, and also the information on the Department of Health HSC websites as well, just to really enforce all the signposting and to really support and all the enablers that you've alluded to, Susan, earlier on, and as well, Sinead. Thank you. That's super. There's another question in around the aspect of payment, which I know you've addressed already. So that's great to see that's as I say, that's been submitted a lot by people as well in advance of the webinar. Another question that's come in is about the requirement, or what is the requirement to inform a GP when a pharmacist prescribe for a patient of theirs? Again,
do you want me to take that, Dawn?
Yeah, thank you.
Yeah. So you'll see that addressed in the PSI guidance in particular. You should have, it's probably covered in the training as well, in terms of how you deliver the service, but there isn't a specific requirement to contact the GP and say that you've delivered the service or that you've issued a prescription. So there's no requirement to have to do that every time you deliver the service. But you might choose to have a conversation with the GP. You might choose to inform them. I'm not sure that every GP wants to know every time you've prescribed something for a patient under this service either. So you'd have to be cognizant of the workload of the GPs also. But you may feel, and you may have a relationship locally with your GP where you've decided that that's actually what you'd like to do. But if you are going to do that, you need to do that in consultation with the patient. They need to give their informed consent for you to share any information with another healthcare professional. And the only situation where that wouldn't arise is if you had a serious safety concern and you felt, look, in the best interest of the patient, I need to communicate. But I think you're more likely probably to be referring in the situation that Sinead is talking, or sorry, to be communicating with the GPs or other healthcare professionals in that situation where there's a referral, and maybe where you've seen a patient and you're now referring because the treatment hasn't worked or they've come back, or even if you just need to refer them because you can't treat them on the day. So in short, you don't have to tell them every time you prescribe, but you would want to maybe have a conversation with the GPs locally in your area about when you might be contacting them, that you are offering the service, and what it might look like, that form of communication between both of you, because it's a two-way process. So you need to involve them and make them aware that this might be something that could happen.
Super. Thanks, Susan. I think that really enforces that piece about what processes work for you, that it will look differently for different pharmacists, different practices, different setups. And again, that local piece on your local collaborations with GPs and other healthcare professionals and how it's going to work. So maybe a really good question to just, remind people of that fact, that it's very much about how it's going to work in practice for you as a service. A couple of questions have come in as well about repeat prescriptions, and as part of the service, can pharmacists issue repeat prescriptions?
Yep. So probably in short, the short answer is yes, but I'll give you the more detailed answer in terms of it depends very much on the protocol. So if you look at Schedule 13, it lists the medication that you can prescribe. There's a column there that tells you that you can prescribe it for a specific purpose, and the purpose is as outlined in the protocol. And you need to refer to each relevant protocol. So there'll be inclusion criteria, exclusion criteria, and a lot of these conditions, they're self-limiting. They won't need a repeat of a medication. So you're not necessarily going to be issuing a prescription for UTI treatment with a repeat on it, because that's not how you'd be managing that situation. But if you look at the protocol around allergic rhinitis, for example, then that's something that goes on for a longer period of time. If you look at the prescribing information, there's nothing to say that you can't repeat. You're prescribing in accordance with the SPC in that particular protocol for the various different pieces. You'll see, for example, with under 18s, you have to review the treatment after 4 to 6 weeks. Don't quote me directly on the protocol, but after 8 weeks, you can't be continuing the treatment. So there'll be specific situations where repeat prescribing may be appropriate, and you can do it where it fulfills all those relevant criteria and it's in the interest of the patient. In terms of the medications themselves, if they're S1A, S1B, the relevant rules apply in terms of how many repeats, etc. you can have. But you can repeat if it's necessary, but just because you can doesn't mean you have to also. So just think about your individual situation, the patient you have in front of you, and of course, you're always working in accordance with the protocols.
Super. Thank you, Susan. I was just about to say that that piece just resonates as well about how the protocols are really there to support all prescribing, which is fantastic. And just to give you a break for a little moment, Susan, and all the questions, just a reminder, please, if anybody has any additional questions, please do submit them to the Q&A box, because I say we're really interested in hearing your questions and hearing and collating those, and I say bringing them to the relevant stakeholders. So really, really, really important if you have any more questions. And I say great that so many have been addressed already. Another question has come in about the end of day printout, and just in terms of what exactly needs to be included on that. So the example is given of if consent is confirmed on the prescription or protocol checklist, does it still need to be on the end of day printout? So you have to take that one, Susan.
Yeah, I can. Yeah. So there's two things that you need to cover off. So the end of day printout, I'm assuming, is what we all know as the daily audit. So on the daily audit, you need to have a record of the decision that you made to prescribe. So you need the pharmacist's name who made the decision, their registration number. Now, I don't have the exact details in front of me, but if you look in the operational guide and the FAQs, they tell you exactly. And you need to give details of the prescription also at that point. So it might feel a little bit like if you then go on to supply that medication that you're duplicating some of that information, but they are two distinct things, and those two distinct things need to be on the daily audit. So you need to have a record of the decision to issue the prescription, and then where the prescription is issued, that's a dispensing event in the normal manner, and the regular details that go on the daily order for the dispensing of any prescription are on the audit in that manner. So you have two things on the daily audit.
Brilliant. Thank you. I know that's covered in the training as well, just to confirm so people can go back and look at that as well. Brilliant. Thank you, Susan. There's a number of comments just flagging as well what Susan's alluded to earlier about the HSE website today and problems with accessing the protocols, just so in case anybody maybe has joined a little bit later, they're obviously well aware of it, and it's been raised as well. So thank you for everybody who's communicated that through the IPU and through the IIOP today as well. So very much being actioned. Another few questions that you'd alluded to, Susan, as well throughout your presentation was about the various medications being covered on the schemes and how that will apply in terms of Schedule 13 and whatever scheme the patient is registered for, if that indeed does apply. Then again, some more advice on aspects you've covered about writing prescriptions, both electronically and in hard copy and through health mail. So great to see those coming in as well. And a very interesting question about if a patient presents and if they're unaware of all their medication history and or allergies, and indeed if you as the pharmacist may not know that detail about the patient, would you refer and or access information from the GP? So a good question in terms of when you don't have the full picture and how that's handled. I don't know, Sinead, maybe if
I might, put up my hand to kind of answer that. And in a way, the simplified thing that you do is you kind of pause your consultation. You explain to the patient how important it is that if they are on other medication, you obviously don't want to prescribe anything that might interact with that. You ask them for the details of their pharmacy, and we're all learning. We will all be open. It's almost like doing an emergency supply, when you have to phone another pharmacy, check what medications the patient are on. And we are the quickest people to phone each other rather than going obviously through the GPs. We know that. So that for me was always the way that we did it. And just that important piece of reassuring the customer that you're better off to pause the consultation, give yourself a minute as a prescriber to check something rather than trying to rush into issuing a prescription.
So just take your time and try and
Yeah.
understand what you have and what then you need to get from there. So, and I suppose it's probably quite similar in practice, as well to what pharmacists are already dealing with and on a day-to-day basis when patients present. And as you say, building on that expertise as well that you already rely on and that you have. Brilliant. Thanks, Sinead. That's fantastic. An interesting question as well about the process with regards, to the grant. So if, for example, you have a training event with your healthcare team, how do you quantify the cost for the claim, and how do you go about the process in terms of actually claiming for it? So I know, Susan, you mentioned a little bit about registration at the start. I don't know, do you want to add to that in terms of the grant as well?
So in terms of the training grant, the details of that, so there's been changes to that under the community pharmacy agreement, and the list of different courses that will be covered is to be agreed. So you'll see in the community pharmacy agreement an indicative list, but there'll be a more official list that will be shared in due course. That process is still being worked out by the various different parties. There will be certain training that you can claim for, and then there's other training that you can't. So it needs to be on that official approved list of training courses in order for you to be able to claim reimbursement for it. So if it's a training course, I'll give you an example. It's not a CCS one, but a technician's course, for example, there'll be an amount of money attached to it, and then you can claim for that. With the common conditions training, what they're going to cover is the time for a pharmacist to do the training, and there will be an agreed rate and an agreed number of hours, and that's what you'll be able to claim for, and you'll need to prove that you've done that training. Again, that process will be outlined. Now, you mentioned there if you did a training event for your healthcare team, that sounds to me like something that's outside of the scope of the training grant. So your own local training activities, if they're outside of that list of authorized kind of courses and approved courses, they're not covered by the training grant. So that's something that you'll be covering locally.
Brilliant. Thank you, Susan. That's fantastic. I think we've just time possibly for one more. And as I say, please do keep the questions coming in. And there's a number of them that have been addressed. And as I say, questions will absolutely be forwarded as well as we've outlined. But some questions coming in about supply of issue of unlicensed medications for medicines that are in short supply.
So again, you need to refer to the protocols here. So the protocols will reference where an unlicensed medicine can be supplied. So that's clearly outlined. In terms of reimbursement support, it's reimbursement support in the normal manner under the community drug schemes. But if people are having any issues in that space, they can always contact us for advice and information. But really, unlicensed medicine prescribing is allowed under this service, and the legislation has been amended to allow pharmacists to be a practitioner who can prescribe an unlicensed medicine. But again, it has to be done in accordance with the relevant protocol.
Okay.
So yeah, and Schedule 13 are the medicines that you can prescribe. So just remind you of that. So Schedule 13 and the prescribing information, the protocol.
Fantastic. That is absolutely brilliant. Thank you, Susan. And I'd say there are just so many questions. We knew we wouldn't get through them all tonight. So as I say, final reminder, please do, if you've any questions, please do include them in our Q&A box so that they can all be addressed. So I might just thank everyone for their questions, and Grace, if it's just possible to put up the last few slides, that would be great. Thank you. So I think hopefully, you're seeing just how important your feedback is and feed forward both in terms of questions and the feedback you're providing in terms of further questions. And as I say, all that Susan has addressed tonight and all that Sinead has addressed in terms of the practicalities and aspects of actually establishing the service in your own practice. So I think, pharmacies, I think a lot to think about. So we would absolutely encourage you as well to please complete the evaluation survey. As I said, it's going to help to inform the IIOP in terms of what information you would like to hear about other aspects of the Common Condition Service. I think if I bring that core theme of journey tonight, it is that it's a long journey, and it's something that is fantastic and to see an evolving space. And as time goes on, we totally understand that pharmacists need to be supported on that journey. So please do let us know in the evaluation survey. It will be issued through your email tomorrow. And as I always say, it would be remiss of me to not flag the fact that there's so much information in tonight's webinar to complete a CPD cycle, or cycles indeed. So please do reflect on the impact and the opportunity to capture your learning, and indeed over time to come. And then I'd just like to say a huge thank you to our panelists tonight. So to Catriona, to Susan, and to Sinéad for your expertise and your time, and for sharing just so much knowledge in this space that is moving so fast at the minute, but in such a positive way. And as a reminder of all the supports and enablers that are there between IIOP, IPU, the PSI, Department of Health, HSE, and there's so many resources there to support the journey. So just to flag that our next webinar is on in 2 weeks' time, again on the 11th of February at the usual time of 8 p.m. And it's going to be delivered by our colleagues from the Medicines Management Programme, who are going to be focusing on the Best Value Biological Medicines Initiative, as well as some more recent initiatives as well within the MMP. So really looking forward to that update. So all that's left to say is a really big thank you to our panelists and to you, our attendees, for your engagement both before and tonight with the fantastic questions, and some really good ones still coming in. So I'd like to say enjoy the rest of your evening, good night, and we'll bring the webinar to a close. Thank you.